I'm very happy to be with you today in front of this prestigious moderation, and would like first to thank Ivo Petrov for his kind invitation and friendship. I'm also very happy to see my good friend, former president of ICVS, Dr. Donald Reid. Donald, how are you doing? Good, I think.
I'm good, thank you so much, Jack. Great to see you.
Carotid instant restenosis is defined by 70% of stenosis in the inner diameter. This problem appears at the rate of 5 to 12% in the different publications I've read. Could be a big problem in the evolution of your patient. Mrs. Tekieli, as early as 2019, say that the optimal management of severe carotid instant stenosis remain unknown. So let's go in the subject. But first, if you are leading one day, please take some time to look behind you. This is important of the story. In France, carotid enterectomy is the gold standard, as you know, and we do a large number of these cases in the French public and private institution. But first, because he's present with us, Dr. Professor Klaus Mathias, from Münster at the beginning and now in Hamburg, was the first man doctor to do an angioplasty in the carotid. It was in 1977. You were a young doctor at that time.
A little bit younger, yes. Not much.
And then you go on 10 years after, or 12 years after, and you did the first carotid stenting. So I would like to congratulate you. Personally. In France, Jacques Busquet, maybe some people know him, and I think, Klaus, you know him. He did an artisanal preparation to do the first stent, striker stent in this occasion with a protection. But people were not so convinced at that time, but he was a pioneer. Dr. Busquet, that we miss very much, from the ICVS say, in any case, the indication for carotid angioplasty with stenting must be decided after multidisciplinary discussion with a vascular surgeon in particular. I agree with that. We all know the authorized carotid stents. There are, at least in France, 4 models, many others in the world. Anyway, we need a neuroprotection system in quite all the cases. And you need also a good and very good interventional suite, as yours, Ivo, because you are very well equipped with, to be able to perform a good cerebral angiography at the end, and digital angiography, and also IVUS in a command for the doctor. Remember that more you do, better you are. And you see, when you start, the damage can be high. So you have to work with a proctor and an older doctor to be trained and become better after 200. It's a lot. Just an example. I did this case some time ago. It was a long eccentric arteriosclerosis, ulcerated symptomatic stenosis, and we treat it by a wall stent. But 6 months after, what happened? Is it an intimal hyperplasia or is it a restenosis? This is the problem. Something is inside the artery. In fact, I did work on the predictors, and I looked to the literature. Preferentially during the first year, strangely, with a diabetes patient, smoker. When you have a neoplasm or leukemia, I think it's because of the inflammation. Or if you keep a residual stenosis after your angioplasty, or a small stent diameter, or if you use multiple stents, not to do. So in fact, for this problem, you have two different strategic options, endovascular or surgical. But remember the multidisciplinary decision-making, considering the specialty involved in the initial procedure. The endovascular option and management are restenting, but maybe it's a lot of material inside. Reballoading, be careful to the embolic problem. Drug-eluting balloon, I've seen that in the literature. I don't know if it's working in the carotid, maybe. Drug-eluting stent, in any case, self-expanding. And the newcomer, the mesh and cover stent, Rotsever and Sigard. Why not? But it's still on experience. The surgical management is very simple and very clear. Stent extraction, endarterectomy, or carotid bypass in some difficult cases. Let me speak with you of one of my recent case reports on a young patient. He was a smoker with a good profession, but a smoker and cannabis. He had leukemia, the history of leukemia, hypertension, and serial pneumothorax treated with drainage. The initial angiography show a severe rad common carotid stenosis distally, treat immediately because of the situation with a cast with nitinol luminic stent. The problem, 8 months later, so within the first year, a very tight stenosis was developed, very tight, that I confirm with an angiography because of the, I just draw on the angiography to let you, there is a little canal. So we join the situation of your previous talk. We took an immediate decision-making for surgical decision, considering the severity of the obstruction. And look, I did clamp and open the artery, and look this bloody stent, full of material, obstructing with the neotentibal hyperplasia, quite the totality of the stent. 8 months after, inside and all along the stent, we were very surprised to do that, but happy to do the surgery. We did the completion of the endarterectomy. Look, we leave the surface clean, and we extract, after the stent, the native atheromatous plaque, and finish by a Dacron patch arterial closure as classical. Importance of the team approach and the echo duplex scan control. And you see that this patient was controlled with a clear diameter on the surface that we treated. It was 10 months after the operation, this control. And you see a very good pulsation. The patient is happy. He was surrounded by his doctor and his surgeon, and this shows a good outcome, hopefully. In conclusion, ladies and gentlemen, Dr. Reid in Glasgow insists on the quality of screening with inside a multidisciplinary approach with a concerted decision-making, use a regular medical follow-up for early reintervention is necessary, and please control the risk factor. I thank you for your attention.
Great talk. Thank you, Jacques. Very instructive. Some comments? Klaus, Vasco?
Yes, there are different therapeutic options, was pointed out. I suggest that next year you organize a talk about treatment of recurrent disease after surgery.
Okay, agree. In fact, probably the audience, one of the reasons the endovascular intervention of carotid to appear was the restenosis after surgery. So nowadays, in the late data with the new technology, the restenosis after carotid stenting is a quite a rare situation. Unless it's a not proper indication. For example, we discussed already, Professor Mathias mentioned that for critical calcific stenosis, it's not a good idea to implant a stent in case it's not well open with a balloon. So in circular calcium, this is probably one of the biggest predictor of instant restenosis. And we had such a situation several months ago. Unfortunately, the patient was a doctor, medical doctor. He had really a critical stenosis 2 times. And on the last incidence, we have discussed yesterday, Vasco, we have used a shockwave balloon with finally excellent result. So in case we don't disrupt the calcium, it's more than clear the stent can be open.
I just want to say that I fully agree that if we have so much material inside the stent and we have a surgical solution, we're happy because it's a solution. But the real problem is with the recurrent stenosis after irradiation therapy. And this is usually not a surgical case because the tissues are very different. So what's your suggestion if we have a post-radiation stenosis and it keeps coming back? So do you see any solution of this problem?
The case I show you was to aware the audience on the inflammatory system of some patient. This patient was probably a bad candidate because of his history. If you have a radiation stenosis, even recurrent, endo, it's always endo, because if you cut down, you will have a problem, even if you are a good surgeon. So radiation, endovascular.
Donald, do you have some comment, opinion?
I liked your presentation, Jacques. Again, it's an important topic that is often ignored.
Thank you, Donald.
And I feel that it's not necessarily restenosis, but the same stenosis that wasn't detected at the time of implantation. And so it's very useful to use 2-directional angiography imaging or intravascular ultrasound at the time of the initial stent to make sure that there is a very good channel through. And then you're less likely to get a restenosis. But you got a good result there surgically. Dr. Mathias mentioned a topic for next year of recurrent stenosis following surgery. Well, Ali Abou-Rama is really the authority on this. He's the current president of the Society of a great deal of evidence to show that the correct treatment for that, of course, is carotid stenting. So those are my comments, Ivo.
Donald, I will be happy to speak with you later, maybe tomorrow or next week, with pleasure.
Thank you. Perfect, Jacques. Good for you.
Thank you, Donald. Thank you for joining us. Even online, your participation is crucial. We miss you.
It's a huge, huge pleasure. Yes, well, I'm very, very sorry not to be there this year. I've been at every single meeting until now.